Hello, everyone. Thank you for joining today's MIPS Call for Quality and Cost Measures webinar. During this session, CMS will provide an overview of the development, criteria, and evaluation of MIPS measures. Topics presented during today's webinar include an overview of the call for measures, requirements for successful submission, measure evaluation considerations, and explore specialty or clinical topic gap areas. This presentation will be followed by a Q&A session where attendees will have an opportunity to ask questions via phone and the support call questions box, and CMS subject matter experts will address as many questions as time allows. You are welcome to submit questions during the presentation or wait to submit your questions until the Q&A portion of the call. Now, I will turn it over to Dr. Michelle Schreiber, Deputy Director for Quality and Value in the Center for Clinical Standards and Quality, and Director, Quality Measurement and Value-Based Incentives Group at CMS, to begin.
Thank you, and good afternoon, or perhaps good morning to those of you in other time zones. It's a pleasure to be with you today, and welcome to the call for MIPS measures. We're looking forward to your questions and any discussion. Can we advance to slide 4, please? There we go. So, as the largest insurer in the United States, covering nearly half of American patients between Medicare, Medicaid, CHIP, the marketplace, the innovation models, CMS does serve the public as a trusted partner and steward, and we're dedicated in particular to advancing health equity, expanding coverage, and improving health outcomes. Next slide, please. This is the new schematic of the CMS Strategic Priorities, with Pillar 1 being advancing equity. There have been a lot of initiatives across CMS for advancing equity, and I'm sure you'll be hearing more of them as time goes on. Pillar 2 is building on the ACA to expand access and quality and affordable healthcare. 3 is all about engagement of our partners, engagement of our patients, and engagement of our communities. 4 is innovation, to tackle some of the health system challenges and to promote high-value person-centered care. 5 is protecting the Medicare sustainability for future generations, and 6 is really internal to CMS of fostering a positive and inclusive workplace. We're really very excited about the CMS Strategic Priorities. Next slide, please. These translate then into what is important when it comes to new measures that somebody may wish to submit. And obviously, I will remind us that any vendor or stakeholder is welcome to submit new measures to merit. And I'm sure that we'll go through this later, but the deadline for submission is sometime toward the end of May in 2022. CMS obviously makes the final decisions about what measures will be included in programs, and we have valuable stakeholder feedback from the National Quality Forum Measures Application Partnership. But the key areas for focus, as I'm sure you can imagine and understand, is first and foremost still the COVID-19 public health emergency. But then equity is really at the top of the list of what's important on the CMS agenda. Maternal health and safety. Some of you may have heard the Vice President's announcement about initiatives across the country to improve maternal health and safety. As well, mental health is high on the list. And as we know, we actually do have some gaps in measures around mental health. Resiliency and emergency preparedness. We've learned many lessons in the COVID pandemic and recognize that we need to not only be reinforcing public health, but looking at how we ensure emergency preparedness and resiliency to be able to respond to challenges of the future. Safety is an important topic. It has been for a long time, but we are calling again for a recommitment to safety. We've noticed during the last 2 years of the pandemic that some of our patient safety performance has really declined, such as healthcare-acquired infections or pressure ulcers and falls. And we need to recommit to safety as a key priority. And it's not just patient safety, but workforce safety, facility safety. So a sort of larger, more holistic picture of safety that needs to be deeply embedded in organizations. Digital transformation we'll talk about. That's another key focus area for quality in moving towards interoperability. We've seen during the pandemic the explosion of telehealth and how valuable that's been, and the absolute need for interconnected and real-time data. Climate change is something that you may start seeing popping up on quality in healthcare, because we recognize that there will be challenges and there are challenges when it comes to climate change and health. And finally, value is always one of the top priorities. I will remind us all that outcome measures are preferred as much as possible, and in particular, patient-reported outcomes. We are committed to increasing the percentage of patient-reported outcomes in our measures because we think the voice of the patient is essential. We're looking for few to no, except with a good reason, process measures, and no measures that just are check the box. You know, did you do this form or something like that? I think that we have moved further in quality than that, and really do prefer outcome, but recognize that there are times when a process measure is important. And the topics we talked about: equity, safety, mental health in particular. The next slide. In terms of future directions, especially for MIPS, we all recognize the transition of traditional MIPS to MIPS value-based pathways, which are really sets of measures that are specific to a certain either specialty or topic area, such as wellness and prevention could be an example, or hypertension could be another example, or orthopedic surgery, bone and joint replacements could be another example. So those are potential examples of MIPS value pathways, which means that we will be promoting subgroup reporting so that within a large multi-specialty group, subgroups can report, such as a certain group of providers who works on a same topic can report as part of the larger TIN, but it would be a subgroup reporting. We are working on equity, not just in terms of measures for equity, but looking at performance measure stratification and having conversations about what is the appropriate direct data collection for this. And finally, I spoke already about digital measures, but this is very important. Our commitment is still to move to 100% digital measures over the next several years. I would be watching the US CDI and what is going on in terms of standardized data elements, because these will become important priorities to be standardizing the way that we are collecting this information over time and ensuring interoperability and the ability of having more real-time data that can all contribute to learning systems. Finally, I want to talk about alignment. We're working very hard across CMS to align our measures portfolio between Medicare, Medicaid, the innovation models, and the traditional Medicare fee-for-service models, as well as working across the federal government to align our measures, including with organizations such as the Veterans Administration, as well as the Department of Defense. And we've been working with NQF and America's Health Insurance Plans to align measure sets across all payers. So alignment is important, and as you're developing measures, look to see where there are opportunities for alignment. With this, I turn it back to Colleen to kick off today's discussion. And again, I welcome you to this conference, and we look forward to hearing your thoughts. Thank you.
Thanks, Dr. Schreiber, and thanks to everyone joining today's call. And please like everyone to take a moment to review our disclaimer for today's presentation. All right, next slide, please. So taking a look at the rest of the agenda for today, we will be reviewing the call for measures process and requirements, considerations when evaluating measures, the transition to MVPs, and resources. And as stated at the end, we will have a question and answer session. Next slide. All right, to kick things off, we provided a quick overview of the call for measures. Next slide. The annual call for quality measures process asks stakeholders, including clinicians, professional medical societies, researchers, consumer groups, to send or recommend quality measures for consideration in the quality performance category for MIPS. Stakeholder recommendations are a large part of our rigorous quality measure selection process, as stakeholders will likely submit what is meaningful and applicable to them in their scope of care. Allie, would you like to review that annual call for cost measures?
Sure, thanks, Colleen. Next slide, please. So what is the MIPS call for cost measures? Similar to the call for quality measures, the call for cost measures is a process for stakeholders to identify and submit measures for CMS to consider for use in the MIPS cost performance category. This is the first year that the process is in place, and it will be an annual process, again, similar to the call for quality measures. The process was established through rulemaking in calendar year 2022 Physician Fee Schedule Final Rule, and the rule provides stakeholders with guidance about measurement priorities and requirements. The priorities and requirements are also covered in the 2022 Call for Cost Measures fact sheet, which is linked to in the resources slide at the end of the presentation, and which we'll talk more about in a bit. Next slide, please, and I'll pass the presentation back to Colleen.
Thanks, Allie. Moving on to the Meaningful Measures Initiative, it serves as a guide to evaluate each measure for inclusion on the MUC list, just to ensure that the selection of measures pursues and aligns with the agency's priorities. Through setting the program's needs and priorities, CMS hopes stakeholders will take this into account when developing measures and submitting them for consideration of inclusion on the MUC list. The CMS quality measurement strategy is continuing to drive towards patient-centered, value-based care through the development, selection, and implementation of measurement that includes accelerating the transition to digital measures, promoting the use of all-payer data, increasing alignment of measures, and representing the patient voice. Next slide. We wanted to provide a high-level timeline for a typical year in which the call for measures opens in January. In the March-April timeframe, we hold educational webinars with the call for measures coming to a close in May. We then use July and August to review the measure candidates and evaluate how the measure aligns with CMS's needs and priorities. We will dive into the topic more in the upcoming slides. By September, we provide feedback to the submitters as the MUC list enters the CMS HHS clearance process. Typically, the MUC list will be published no later than December 1st to gear up for those MAP meetings that occur in December and January. The MAP recommendations are then published by February. Also, just as a level set, the MAP or Measures Applications Partnership is to provide recommendations on the measures to HHS with the overall goal to maintain transparency and encourage public engagement. We have wrapped up the MAP meetings for this year, and we hope to see you all there next year. To go over the timeline, the stakeholders submit measures to CMS via the measure submission platform on Merit. Measures are reviewed by CMS and the appropriate contractors at multiple levels. Measure decisions are then communicated to the submitter. Approved measures are then placed on the MUC list and enter the CMS HHS clearance process, with the MUC list being published on the NQF website. Then submitters are invited to the NQF Measure Application Partnership or MAP Clinician Workgroup meeting and are expected to attend to provide any information needed. MAP Clinician Workgroup measure recommendations are reviewed by CMS, and the submitters are again invited to the MAP Coordinating Committee meeting and expected to attend to answer any questions. The final NQF MAP decisions are published and reviewed by CMS, and then the CMS rulemaking team makes final determinations upon which MUC list measures will move forward to be considered for the MIPS program, and then measures will be finalized during rulemaking and would be implemented and available for reporting the following year. Next slide. In order to be considered as a MIPS measure, a submitter is required to submit a few different items. Obviously, first and foremost, we need the measure information along with the peer-reviewed journal article template for quality measures. All measures need to be fully developed and tested at the clinician level and feasible at the time of submission to the call for measures. There may be additional outreach to gain clarity if the team has questions as the measure is evaluated. And as a reminder, measure submission has moved to the Muck Entry Review Information Tool, or MERIT, for the 2022 call for measures. Moving on to after the submission, if a candidate measure is placed on the Muck list, the submitter is expected to attend the NQF-MAP meetings that were just referenced in the previous timeline. This allows stakeholders to ask questions, provide feedback, and fully understand the measure prior to engaging in the voting process. And then finally, if the measure is proposed and finalized, the measure steward would maintain the measure through the annual revision process. The process ensures measure aligns with the current clinical guidelines, that coding is updated as there are annual revisions to the ICD-10 CPT coding. We do promote coordinating measure changes across collection types for quality measures, across governing bodies and other CMS programs, as this will contribute to reducing reporting burden. And additionally, we do request the attendance of measure stewards on the measure steward meeting hosted by CMS as scheduled. Next slide. And just some more additional measure maintenance expectations for those measure stewards of eCQMs. During the annual update cycle, measure stewards are expected to participate as well as understand and apply standards, which would include QDN, CQL, and FHIR, make and test technical changes, and support responses to stakeholder questions while adhering to the timelines and processes outlined for each annual update. I would like to note that this is a distinct update cycle, and it does begin earlier than the update cycle for other quality measure collection types. Next slide. And now we will be moving on to measure requirements. Next slide. Looking at the fully developed definition, measures that are fully developed are highly preferred, as Dr. Schreiber indicated. Critical data elements should have patient or encounter level testing. This would be noted as a yes in row 47 of the 2022 Muck list data template in Word. Additionally, completion of reliability testing at the accountable entity level, which is noted as a yes in row 24 of the template. And completion of empiric validity testing at the accountable entity level, which is noted as a yes in row 38 of the Muck list data template in Word. Please note that while face validity, as noted in row 44 of the 2022 Muck list data template in Word, does not meet fully developed criteria, however, it will be temporarily accepted for new measures. Next slide. Additionally, for those measures based on survey data or patient-reported tools, it would be expected that the survey or tool has also been tested, which would be noted as a yes in row 59 of the Muck list data template in Word. Please note, if you wish to proceed with the submission of a measure that is not fully developed, please provide additional details regarding development status in CMS Merit, as well as filling out all information requested. Next slide. As I had mentioned, for a measure to be considered, it must be tested at the clinician level or the entity level for MIPS, which is the entity level for MIPS at the time of submission. This includes reliability testing to ensure the measure can reproduce results. This can be demonstrated by signal-to-noise ratio. We also require that a measure is valid and accurately represents the concept and achieves its intended use. We would direct you to the CMS blueprint for additional guidance on testing, and I've also included the link within the resources section of the slide deck, as well as the next slide. Next slide. Additional testing requirements for eCQM measure testing and readiness include the measure output output in the form of the health quality measure format using eCQM standards. The data collection mechanisms must be able to transmit and receive requirements as identified in MIPS regulation. Additionally, the specification has MAT outputs to include HQMS, human readable files, value sets, and Bonnie test cases showing 100% passing and 100% coverage. Feasibility can be shown utilizing the NQF scorecard, and reliability should be in signal to noise ratio and validity in the correlation of outcome with related processes. Please see the additional measure resources for eCQM related questions. Next slide. All right, looking ahead, we wanted to put this on your radar for the future, though I think most people are familiar with it. The FACT Healthcare Interoperability Resources, or FHIR, is a data interoperability standard developed by HL7 International for the purposes of exchanging healthcare information electronically. FHIR combines a simple framework of building blocks or data elements with the latest web technology to standardize the way healthcare data is represented and shared. It is flexible enough to be used across a variety of EHR and other healthcare exchange platforms, as well as accommodate complex healthcare data needs. So how would this impact the eCQM? Instead of using QDM data elements and QRDA reporting, the FHIR data model and FHIR reporting requirements would be used for representing and reporting the eCQM data. The FHIR standard has the potential to reduce overall burden on measure developers and implementers by providing faster, real-time access to quality data, align data exchange standards with clinical data support initiatives, and automate both EHR data retrieval and quality data submission. So exciting things are definitely happening in the world of eCQMs. Next slide. Beginning with the 2020 Call for Measures process, submitters were required to link their MIPS quality measures to existing and related cost measures and improvement activities as applicable and feasible. Submitters are required to provide a rationale as to how or why they believe their measure correlates to other performance category measures and activities as part of the Call for Measures process. This will aid in our development of robust and cohesive MVPs. The submitters may also link the measure to a previously finalized MIPS value pathway, or MVP. And we will discuss the transition to MVPs later in the presentation, but wanted to note this requirement. Next slide. All right, next we're going to move on to talk about measure evaluation and considerations. Next slide, please. Each year, CMS assesses the quality measure inventory and identifies specialties and clinical topics that are not widely represented within the MIPS quality measure inventory. We would request measures that support these measurement gaps. From our initial review, we are seeking measures applicable to the specialties and topics listed on your screen. As Dr. Schreiber mentioned, we really seek to have the patient voice represented in quality, whether it be from a patient-reported outcome or a shared decision-making measure. Next slide. In addition to those specialties and clinical topics shown on the previous slide, CMS also assesses the quality measure inventory for alignment with other priorities and focus areas. These include increasing the number of outcome and digital measures within the inventory, looking for measures that represent care coordination, communication, and team-based care, and new measure options for those specialty areas that contain topped-out measures, as well as measures that focus on or address health equity, COVID-19, and of course, the patient voice. Next slide. As stated previously, we do seek to move towards more outcome-based measures to include patient-reported outcome performance measures that utilize PROM. Patient experience measures aim to improve customer experience that support innovative approaches to improve quality, accessibility, and affordability, and most importantly, empowering patients and clinicians to make decisions about their healthcare together. This incorporates the patient voice, which is a priority within CMS. Next slide. So we aim to reduce the reporting burden for clinicians. You may notice that we have been adding administrative claims measures. These do not require additional action on behalf of the clinician, but are automatically calculated using claims data. Additionally, implementing digital quality measures, or DQMs, that leverage sources of health information that are captured and can be transmitted electronically and via interoperable systems will assist in this effort as well. And we will continue to improve our digital strategy by using FHIR-based standards to exchange the clinical information through application programming interfaces, or APIs. And this would allow clinicians to digitally submit quality information one time that can then be used in many ways. Accelerating the transition to fully electronic measures, working across CMS to use artificial intelligence to identify quality problems before patients are harmed and intervene accordingly, and developing more APIs for quality measure data submission and interoperability. Alignment across CMS programs is looking to align measures across programs so that those clinicians who participate in multiple programs will have decreased burden, as they will not have to implement the same measure concept in multiple ways based upon the program. Next slide, please. Now we're going to look at the quality measure roadmap to the MUC list and some do's and don'ts. So each year we receive and review measure candidates and provide consistent feedback to combine, revise, etc. We wanted to walk through typical detours to consider when developing a measure so that your measure has a better opportunity to move forward to the MUC list and eventually MIPS implementation. First, review the composite format. Is it all or none, any or none, etc. A great example of what types of measures we are looking for is measure 441, which is IVD optimal care. This takes a more comprehensive approach to managing or caring for patients with IVD by assessing multiple components that include blood pressure is controlled, tobacco use cessation or non-use, taking an aspirin or antiplatelet, and statin unless contraindicated. What we don't want to see is those 4 components come in as 4 different measures. Next, we don't want submissions that duplicate or are one-off to existing MIPS quality measures. We really encourage collaboration with MIPS measure stewards to be inclusive of appropriate clinical settings and patient populations. For example, a measure doesn't contain the inpatient setting, but you feel it is applicable to this setting. We don't want to see this measure submitted as a separate measure, but rather we would encourage you to reach out to the measure steward to see if they are open to expanding the clinical settings represented. Next, as measures are submitted, we do look at the burden that they may pose to the clinician or group, and we would encourage the development of measures that also take into consideration, especially leveraging the digital tools that were mentioned earlier. This last one on this slide is an important aspect. Please ensure to evaluate your measure for any unintended consequences. For example, a cost resource use measure that deprives oncology patients with shortness of breath of palliative oxygen therapy would be an example of something we would not want to see. Next slide, please. All right, moving on to the next slide of do's and don'ts. First, on this slide is submitting a measure that only captures an assessment or that a survey was completed. This top one is probably the most common scenario that we see. We will not move forward with these measures and will request that you combine into a single measure that emphasizes a robust quality action. However, if you want to measure the assessment rate separately, there are options that you may utilize to develop your measures to do this. For example, measure 226, which is tobacco use, screening, and cessation intervention, does have 3 different performance rates that can show, 1, who received screening for tobacco, who received who, if they were a tobacco user, received cessation intervention, and then an overall performance rate of all patients who were screened and then received cessation if necessary. So if this delineation is important, there are opportunities to provide more granular data to the clinician. As previously mentioned, we are looking for outcome, patient-reported outcomes, or intermediate outcomes measures, and I believe this is very apparent in many CMS resources. Moving along, measures should align with the current guidelines, and if not, would not be considered for the MUC list. For measures already in MIPS, each year during the maintenance process, the measures should be updated to align with the current guidelines. If a measure remains misaligned and likely to produce misleading results, it may be suppressed until the measure is updated. While we do not score these measures, it does place burden on the clinician to collect data that may not contribute to their final MIPS score. We do rely on the measure stewards to alert CMS of guideline issues. Moving on to attribution. Attribution is the assignment of the results of a measure to a reporting clinician or group. MIPS is a clinician group-focused program, and we want to implement measures that are attributable to the clinician group or virtual group. For example, we have seen measures that look at medication shortage or equipment supply, which does not speak to the care the clinician group is providing. These types of measures would not be appropriate for the MIPS program. And lastly, on this slide, all components of the measure should consider the evidence. Denominator exception medical reason should be precisely defined and evidence-based. A broadly defined medical reason, such as any reason documented by clinician, may create an uneven comparison if some clinicians apply reasons that may not be evidence-based. However, medication specified in the numerator is shown to cause harm to fetuses, and the patient's pregnancy is documented as the reason for not prescribing an indicated medication. This should not negatively affect the clinician's performance, as there was evidence-based support not to prescribe the contraindicated medication. Next slide. Moving on to our last slide of the do's and don'ts, we ask that you do not submit a measure that is a never event with no variability between clinicians' performance. For example, while we never want a FHIR in the operating room, they occur so infrequently that it is not a meaningful measure. When looking at complications, measure developers should ensure that they are trying to close a gap in a given complication or event. They are important measures, but we also have to consider the method in which we score the clinicians and groups. If they're less than a percentage separating the top performer from the bottom, it is hard to say one clinician is doing significantly better than the other. Lastly, we don't want to see measures assessing the standard of care or measures that are just considered low bar. This relates back to the consideration of how we score within MIPS if there is little variability or gap. In these cases, it is hard to differentiate performance among clinicians. Measures should ensure a performance gap exists through testing and investigate opportunities to revise the measure to include a comprehensive and robust quality action. Next slide, please. All right, so we've now made it through the do's and don'ts. As mentioned, we do request that performance is included within your submission. Measure performance and evidence should identify opportunities for improvement. CMS does not intend to implement measures in which evidence identifies high levels of performance, meaning that there is little variation or opportunity for improvement. As an example, we would consider these measures top-down. Also, when developing measures, we would like you to consider the tools used within the measure. They should be standardized, validated tools that are non-proprietary and can be used by everyone. Lastly, the measure should be intuitive or show high face validity. This is important as this information can be viewed by patients within CareCompare. And now I will turn it over to Allie to discuss the specific cost measure considerations.
Thanks, Colleen. So yes, now to review some considerations around cost measure development, starting with how cost measure development relates to the current MIPS cost measure inventory. Among other considerations, CMS looks at the extent to which the measures further the goals of CMS's Meaningful Measures Initiative and how consistent the measure is with other measures in the MIPS cost performance category. The measures in the MIPS cost performance category share the following features. They define episodes based on medical codes that determine the patient cohort and identify a clinician-patient relationship for a particular type of care being assessed. They specify which costs are included in the measure. They apply exclusions to ensure completeness of data in a fairly comparable patient cohort. And the measures use a risk adjustment approach to account for differences in clinical and other risk factors that affect cost. The measures shouldn't be duplicated or redundant with a current cost measure. And if you're looking for more information about which measures are currently included in the MIPS cost performance category, you can take a look at the QPP website, which includes an inventory of the current cost measures. Additionally, CMS prefers measures to have the potential to be used in an existing or future MIPS value pathway, or MVP, to assess the value of care for a defined clinical topic. Next slide. Regarding considerations around measure construction, testing, and specification, CMS also considers the following factors when reviewing submissions. Does the submitted measure have complete specifications and require testing information? Is the measure based on measure specifications that have clinical face validity, and are the specifications consistent with practice standards? Do the measure specifications allow for consistent calculation and reproducibility using Medicare claims data? Does the testing information in the submission demonstrate variation to help distinguish cost performance across individual clinicians? Does the measure have clear ex-ante attribution to clinicians? That is, could clinicians anticipate when their responsibility for a patient begins under the measure? Does the measure include the cost of services that reflect the role of the attributed clinician? Is the construction methodology readily understandable to clinicians? And can the measure be presented in a way that conveys clear information on how clinicians can alter their practice to improve measured performance? I realize I've given a lot of information across the past 2 slides. So in addition to having these slides to refer back to once posted, I'll refer you again to the 2022 Call for Cost Measures fact sheet, which includes the same information and more, and is available in the QPP resource library. Next slide. So on this slide, I'll review specialties with limited episode-based cost measures. This slide is specific to the episode-based cost measures, and these specialties may have applicable population-based cost measures. For example, total per capita cost, or TPCC, or Medicare spending per beneficiary, MSPB, clinician. The specialties listed on this slide were identified through an empirical analysis using 2019 administrative claims data and represent specialties for which current episode-based cost measures and cost measures under development have limited applicability. You'll also note that a few of the specialties on this table have an asterisk. The asterisk identifies specialties that are being considered as clinical topics for the next wave of development prioritization. Another important thing to keep in mind while developing cost measures is that within each specialty, there may be multiple clinical topics. For example, podiatry could include evaluating and treating foot injury, managing foot infections, and treating foot changes such as bunions. There might also be clinical topics that involve multiple specialties. For instance, screening for female preventive health could involve obstetrics and gynecology, family medicine, internal medicine, and other specialties. While I pause here to give you a moment to review the specialties listed on this slide, I'll again put in a plug for the 2022 Call for Cost Measures fact sheet, which again is available in the QPP resource library. And then as we go to the next slide, I'll pass the presentation back to Colleen again.
All right, thanks so much, Allie. Now, as promised, we'll go over the transition to MVP. Next slide, please. It may not be a surprise to most of the attendees today, but CMS is looking to transition to MIPS value pathways, otherwise known as an MVP. The goal of these MVPs is to create a more cohesive participation experience by connecting activities and measures, resulting in a more value-focused program with a reduction in selection burden. So how do we take that into consideration during the call for measures? We will look to see if the measure candidate aligns with the MVP framework by looking to see how it complements the improvement activities and other measures, both cost and quality, depending on the measure being submitted. This will be an important link moving forward as we transition to MVP. MIPS value pathways are a subset of measures and activities that are established through rulemaking, and the MIPS program aims to drive value through the collection, assessment, and public reporting of data that informs and rewards the delivery of high-value care. Within MIPS, we intend to pay for healthcare services in a way that drives value by linking performance on cost, quality, and the patient's experience of care. Next slide. Next slide, please. All right, and next we will go to resources. Next slide, please. And just please review these resources for any additional guidance given here for any follow-up questions that you may have for the call for measures. And with that, I will hand it back to Emily.
Great, thanks so much. We're now going to start the Q&A portion of our webinar. You can ask questions via the Q&A box or through the webinar audio. To ask a question through the webinar audio, please raise your hand and we will unmute your line so that you can speak. To submit a question anonymously via the Q&A box, please click Send Anonymously. Otherwise, all attendees will be able to view your question. And I'll give folks just a minute to either raise their hand or submit.
Hi, everyone. I think we are experiencing a little technical difficulty with Emily's audio. So to repeat what she was saying, if you are interested in asking a question, please either raise your hand using the hand raise icon in your go-to menu or submit your question through the question and answer box, and we will take your question via the phone then. So we'll just give it 1 minute to see if anyone has questions that they would like to have answered related to this topic. I'm not seeing any questions that have not been addressed already. So we'll just hold on another minute and see if any further questions come in.
Hi, this is
it
Lisa
does.
Marie Gomez of CMS. Sorry, Lindsay. I just want to say, and we just want to encourage you, and I know some of you in the Q&A chat are indicating that there's a lot of information to digest and you're digesting the information, but we definitely want to provide you an opportunity to ask questions with regard to the submission of quality or cost measures for MIPS consideration, which, as you know, would be part of the MUC list if those measures are submitted and would be under consideration for MIPS. So we just want to encourage you to submit questions, or if you don't have any questions now, I just want to note that if you do have questions later on, maybe tomorrow or next week, please do not hesitate to reach out to the Quality Payment Program Service Center at qpp@cms.hhs.gov if you have questions. So even if you can't answer or have questions right now, you can always submit questions at any point in time. So I just want to highlight that for you. And we'll just give you a few moments if you still have potential questions that you want to ask. So I just want to highlight, this is Lisa Marie Gomez again with CMS. We are getting more questions in the chat, so we are going through those questions and looking to address them. So just give us a few moments while we go through them and we will be addressing them. Thank you for submitting your questions.
Okay, we do have a question, so we'll start. This question is, how are the priority areas for cost measure development determined? In the rule, there was discussion of specialty societies developing these. Will methodology training be offered?
Hi, this is Joyce Lamb from the cost team. Thanks for this question. And in terms of how the priority areas were determined, this was based on empirical analyses using administrative claims data. Specifically, we looked at 1 year of data, 2019, and the coverage of the current MIPS cost measures across all the specialties. And we looked to see where there were lower percentages of coverage by specialty. And so that's basically how we came up with this list. In terms of specialty societies, it also reflects the input that we've heard from stakeholders over the years. For example, where specialty societies have commented saying that there is limited availability of cost measures at the current time. So this is also something that we took into consideration, but mainly we looked at the empirical data in terms of identifying gaps. That's not to say that this is the only set of specialties that need cost measures. There are certainly more clinical topics, more specialties where, as Ali mentioned, a given specialty may touch many, many different clinical topics. And if there are clinical topics that stakeholders interested in cost measure development believe need to have a cost measure and there's meets all the other criteria that we talked about, such as opportunity for improvement, then of course that's something where we really rely on the expertise of stakeholders to identify these topics, and so that they can be considered as part of this CMS pre-rulemaking process. In terms of methodology, there's no specific training for methodology, but there are resources which detail how the current MIPS cost measures do attribution, measure calculation, all the steps in measure construction. So I believe those resources are linked. They are available in the QPP resource library in the measure information forms and the measure codes list.
Okay, great. I think we have time for one more question. So this question is, with regard to new quality measures being developed, has any thought been taken or has there been discussion about not selecting quality measures that require users to purchase the tool that the measure has in the specifications? It makes it a bit unfair when those kinds of measures are put forth, as many groups do not want to purchase the tool for the measure.
Hi, this is Colleen. As we talked about on slide 32 of the presentation, we do look for the use of standardized validated tools that are non-proprietary in order to kind of mitigate this concern of needing to purchase a tool and stuff. So this is definitely something that we take into account, and it will be a consideration for new measures submitted.
Okay, I think that looks like all the questions we have right now, so we can turn it back over to Lisa Marie Gomez to conclude today's webinar.
Thank you. I want to thank everyone for joining us today as we discuss the process for submitting quality and cost measures through the call for measures process. We're excited that you all are excited, or at least wanting to know more information about that process. We are encouraging organizations to submit measures, especially measures that are within our priority areas and our need areas and our gap areas. We, as you know, every year we do review these measures, and it's always great to see new measures that come through our program as we enhance our measures and go for more robust measures, and also expanding the number of measures in terms of specialty within our program. So again, if you have any questions that you weren't able to ask today, please submit those questions to the Quality Payment Program Service Center at qpp@cms.hhs.gov if you have other questions at any point in time. And again, we want to thank you for joining us today, and we all hope you have a wonderful day. Take care. Bye.